Sinai, and I am thrilled to speak to you today about how to utilize a dietitian in your GI practice. So, first, we should ask why collaborate with dietitians? Well, people with chronic GI diseases and disorders are at risk for malnutrition, and evidence supports diet therapy for improving quality of life and outcomes in people with GI diseases. So, dietitians can really help to support physicians and patients by educating on evidence based diet therapies, identifying nutrition imbalances, and providing recommendations that are evidence based for helping to improve our patients' quality of life and outcomes. The first place we should start though is with screening because maybe you don't want to send all your patients to a dietitian, but it's really important to stratify your patients into low and high risks so that we can prioritize those patients who would do best from and benefit from time with a registered dietitian. So the first place you start is nutrition screening, which is a process of identifying individuals who may be at nutrition risk and benefit from assessment from a dietitian. Now, your screening tool should be valid and reliable. It should be quick, easy, and require minimal training. And it's the position of the AND, or the Academy of Nutrition and Dietetics, that based on current evidence, the malnutrition screening tool, or the MST, should be used to screen adults for malnutrition, regardless of patient age, medical history, or setting. So, this is a great tool you can use in your ambulatory clinics or in the hospital setting to really understand if your patient's at risk. And it consists of two questions that you'll see on the right side of your screen, which are: have you recently lost weight without trying? And have you been eating poorly because of a decreased appetite? Now, depending on your patient's answers to these questions, this will generate a score and determine whether or not your patient's at risk or not. And so, if your patient's at risk, then you want to refer them to a dietitian. And as a dietitian, we do a variety of things with our patients. First, we assess them based on how they are nutritionally, considering factors such as client history, medical and surgical history, medication and supplement use, specific diets they're on, and whether or not we think that they're meeting their nutrition needs. And then we come up with a nutrition diagnosis based on what the current nutrition problem is, and we develop targeted interventions to address that nutrition problem, and then implement monitoring and evaluation strategies so that we can assess and reassess whether or not the patient's meeting their goals and what we need to do to change the nutrition plan to help really optimize our patient. But basically, we help people understand how to nourish themselves in a way that appreciates them as a whole, their medical history, culture, tolerances, allergies, symptoms, and life in general. Now, there are specific evidence-based diet therapies for GI diseases and disorders, and I'm going to review the evidence supporting diet therapy for these 5 conditions. So let's start with IBS. Major medical societies recommend lifestyle and diet advice as part of first-line treatment for people with irritable bowel syndrome, or IBS. General diet advice, exercise, and relaxation management are important components that can improve IBS symptoms and quality of life. Now, if first-line treatments are ineffective, then guidance on elimination diets, such as the low FODMAP diet, for the least amount of time it takes for symptoms to improve, is recommended. The recommendation for a low FODMAP diet in IBS is weak and based on very low-quality evidence. Diet trials of low FODMAP and IBS are small, heterogeneous, include dietitian support, which isn't always the case in the real life scenarios, and are highly biased, meaning the benefit seen is likely to be overstated. A multi-center, parallel, single-blind, randomized controlled trial examined the effect of 4 weeks of a low FODMAP versus traditional diet advice on IBS symptom severity, and found that both diets significantly reduced symptoms. There was no significant difference between groups. Another study, which was a single center randomized controlled trial of patients on 4 weeks of low FODMAP diet versus modified NICE, which is the National Institute for Health and Care Excellence, looked at reduction in IBS symptoms over 3 to 4 weeks. Both groups had a reduction in IBS-D symptoms. However, there was no significant difference in overall symptoms between groups. So a modified NICE diet was as effective as a low FODMAP diet. So I just want to emphasize that we don't always have to jump to the most restrictive diet therapies for our patients. We should really start, especially with IBS, with general diet advice for helping our patients recapture symptom control. For inflammatory bowel disease, the IOIBD, or the International Organization of the Study for IBD, recently published guidelines for diet modifications for patients to help control and prevent disease relapse. Now, these recommendations were separated between Crohn's and ulcerative colitis, and they provided a list of foods to include and a list of foods to decrease in the diet. Overall, for people with Crohn's disease, they recommended an increasing intake of fruits and vegetables. And in ulcerative colitis, they recommended increasing intake of omega-3 fatty acids. These components specifically have been shown to modify the gut microbiome, help to control symptoms, and help to reduce risk for flares over time. The recommendations for foods to decrease had high overlap between Crohn's and colitis, and overall, the recommendations were to decrease intakes of red and processed meats, saturated and trans fats, dairy fat, palm oil, and coconut oil, as well as food additives such as emulsifiers, carrageenans, artificial sweeteners, maltodextrins, and titanium dioxide. Now, for patients who are looking for specific diets to follow, there is established evidence supporting exclusive enteral nutrition, or EEN, for inducing remission in Crohn's disease. It's been shown to help decrease inflammatory cytokines, promote fistula closure, and even serve as a bridge to safer elective surgery. Now, this is a very restrictive diet. It involves excluding all food components and relying on a formula to nourish the individual for a period of 6 to 12 weeks, which can be very challenging for people to do. For those who are looking for the same effect for decreasing inflammation beyond, managing symptoms, but are not able to follow an exclusive enteral nutrition approach, partial enteral nutrition is another form of diet therapy that can be considered. This has been shown to help maintain remission in Crohn's disease. A randomized controlled trial found relapse rates significantly lower for patients who followed a partial enteral nutrition group versus a regular diet. And a meta-analysis showed that there was a twofold increase in the odds of achieving remission in patients with moderately active Crohn's disease on partial enteral nutrition and infliximab. So here we can use a partial enteral nutrition approach as combination therapy to help induce remission, or as a strategy to help maintain remission in patients who have achieved quiescent disease in Crohn's. Now, partial enteral nutrition doesn't involve exclusively drinking a formula. Patients usually achieve this by replacing about 1.5 meals with formula and then receiving the remainder of their nutrition from a general healthy diet. Now, as far as diets based on real foods and how they decrease inflammation, there is emerging evidence suggesting that certain diets can help to not only manage symptoms, but also decrease inflammatory biomarkers and potentially help with mucosal healing and improvement. The specific carbohydrate diet is one that's very popular in the IBD community. This is a very restrictive diet that includes avoidance of all grains and certain sugars in the diet, and is really rich in whole foods such as plain unadulterated meats, fruits and vegetables, nuts, seeds, and certain legumes. There's also one case series that found symptom improvement in patients with IBD who followed the anti-inflammatory diet. This is a diet that was invented by researchers at the University of Massachusetts and is currently being studied in a pregnancy population to understand the effects on the fetal microbiome and risk for development of IBD later in life. It's kind of an updated version of the specific carbohydrate diet, so it is restrictive in the grains and the sugars and emulsifiers in the diet, and puts an emphasis on whole foods, prebiotics, probiotics, and ensuring nutrition balance. And there's also some evidence to support a Crohn's disease exclusion diet. A recent study showed that this was better tolerated than exclusive enteral nutrition and equally effective in inducing steroid-free remission at 6 weeks. The Crohn's disease exclusion diet is kind of a partial enteral nutrition diet, so there is a formula component to this diet. There's a list of foods that are mandatory for the patient to eat, so they have to eat things like chicken, eggs, apples, potatoes, and bananas every day. There's a list of foods that are allowed on the diet, and then there's a list of foods that they have to exclude or avoid, which are mostly red meats, gluten, certain sugars, food additives, and emulsifiers that may be found in a traditional diet. Nutrition therapy goals for people with pancreatitis include helping to control symptoms, mostly abdominal pain, and reduce risk for flares. Now, we can achieve this through small, frequent meals, encouraging a balanced diet rich in whole grains, fruits, and vegetables. One study showed that meat-rich diets are independently associated with the development of severe disease in patients with acute pancreatitis, so really encourage more of a plant-based diet that's nice and balanced. And then limiting fat. So we want to encourage 30 to 50 grams of fat per day, kind of spread throughout the day, as that helps to improve tolerance. So encourage patients to have more baked foods, broiled foods, grilled foods instead of fried, and avoid things like animal skin, as well as cutting off visible fat from meat. We also want to encourage hydration of about 2 liters of fluids per day and avoid alcohol. And during flares, patients may need to limit to liquids or nutrition support, such as oral nutrition supplement shakes or tube feeding. Celiac disease is a chronic disease in which atrophy and distortion of the small bowel occur with gluten ingestion. So the only treatment is for people to follow a gluten-free diet. Now, gluten is the common name for source proteins or prolamins found in wheat, rye, and barley. So a gluten-free diet includes avoidance of wheat, rye, and barley, and in some patients, oats due to cross-contamination or specific intolerance to that food. Foods that are naturally gluten-free are listed on the right side of your screen and include things like plain meat, poultry, fish, eggs, milk, yogurt, and cheese. Legumes, although some studies have shown a high cross-contamination rate found in lentils, so I encourage my patients to sort lentils and rinse them before consuming or preparing their lentils. Plain nuts and seeds are naturally gluten-free, plain fruits and vegetables, and naturally gluten-free grains such as amaranth, corn, quinoa, millet, teff, buckwheat, rice, and sorghum. And lastly, I just wanted to touch on colorectal cancer prevention. There is strong evidence linking diet, weight, and exercise to CRC risk. Studies show that diets rich in fruits and vegetables and whole grains decrease risk of CRC, and red and processed meats increase risk for CRC. So really encourage patients to limit red and processed meat intake. Alcohol also increases risk of CRC, so limit alcohol to less than or equal to 2 drinks per day for men and less than or equal to 1 drink per day for women. Other lifestyle factors that can decrease risk for colorectal cancer include encouraging exercise and avoiding smoking. In summary, dietitians help guide patients through evidence-based, balanced, and personalized diet therapies. Screen patients with the MST or the malnutrition screening tool to stratify patients into low and high risk, and refer patients when appropriate to a dietitian for further education and intervention. Diet therapy has been shown to improve quality of life outcomes and mitigate risk in GI diseases and disorders. And consider these diet therapies based on your patient's diagnoses. For IBS, general diet advice versus a low FODMAP diet. For IBD, the IO-IBD diet guidelines, or exclusive enteral nutrition or partial enteral nutrition for Crohn's disease. For patients with pancreatitis, encourage a balanced diet, small frequent meals, and low-fat foods. For patients with celiac disease, strict adherence to a gluten-free diet is recommended. And for CRC prevention, encourage a high fiber diet rich in fruits, vegetables, and whole grains, and limit alcohol.